Caring for Kids God's Way, a biblical counseling certificate program in child advocacy developed by the American Association of Christian Counselors through Light University. Your ministry is to be a Galatians 6:2 helper. Ours is to equip you with the highest level of advanced training from the world's leading Christian counselors. 24 experts teaming up to create the most comprehensive child studies curriculum for the personal classroom. May the Lord bless your study as you begin caring for kids God's way. Director of ARC Psychiatric Services in Atlanta and a frequent contributor to Christian Counseling Today magazine, Caring for Kids God's Way presents Dr. Glenn Havens, Kids and Modern Medications.
This is not one of those topics that people find exciting. The topic is medications and an update on medications. I know that many of you will be interested in this, and many of you want to know what's out there. But it is also somewhat of a cut and dried subject. What I'd like for you to do for you today is to go through the different classes of medications that are available, and then talk about the different medications in each class. Then we'll talk about diagnoses and what kind of medications are used for different diagnoses. Also, the kinds of symptoms that are used with different medications, so that when you talk with your friends or your relatives or your physician or your pediatrician or your child psychiatrist, you'll be able to ask questions that have meaning for you, because many times the names of medications are very confusing. And you may have 2 or 3 different medications that your child is given, and you may not know exactly why they're being given. I've said something about this before in the video about ADD, but I'd like to say it again for those of you who are just looking at this video. It is very difficult many times in the Christian community for people to understand why we use medications and why Christians in particular have emotional problems. Many times we feel like it somehow is inherently spiritual, and that if we simply got things where they needed to be somehow, we wouldn't need medication. Medication is viewed sometimes with hesitancy, sometimes with suspicion, and sometimes simply with a lack of knowledge. And so how do you decide what is good to take and what isn't, and what's reasonable and what's not? And those are some of the questions that I'd like to answer for you today. I'd also like to say that from my standpoint, as a psychiatrist, I've had to figure out for myself where this particular aspect of medicine fits in the Christian community and in the whole concept of mental health. The concept or the thought of the fall is one that's familiar to everybody. We all know that when the fall occurred, that everything in nature was touched by the fall. That includes man's separation from God, from himself, which I happen to think is probably the unconscious, that we are actually separated from ourselves. We're separated from others. That's what relationships about. We're also separated from our bodies. It is very clear that the mind and the body have a tremendous interface, and that many responses in the body are induced by what's going on in your mind. There's also separation from nature. When you look at the physical side, what we see is that different people have different proportions, or shares, if you will, of the fall. Some people have more physical impairment than others. Sometimes it's their fault. Sometimes it is their parents' fault. And sometimes it is what God has chosen to do for God's own reason. We see the same thing when it comes to mental health or emotional problems. The sins of the fathers, I think, in in a very real way, are patterns in families that are passed down from generation to generation, that unless something is done to break the pattern, the children will end up, regardless of what is said, the children will end up behaving and solving problems and relating the same way their parents did, and their grandparents before that. Sometimes it's things that we do to ourselves that cause us emotional problems. For instance, using drugs can put your brain into an imbalance that requires medication. And sometimes God chooses to do what God chooses to do for his own reason. I think the story of Nebuchadnezzar is a very good one to illustrate this, because it's clear that he experienced a psychotic episode where, and this was done because God had a specific purpose in it. When it comes to looking at the brain and the different kinds of things that we call mental or emotional disorders, it is very clear now that the brain itself is not functioning normally. In past years, there was a lot of opinion as to what an illness was, or whether something like depression was a character flaw. There was a lot of discussion as to whether or not depression should be and could be treated, whether or not we were avoiding dealing with problems by medicating them. Not that this is not a valid criticism in times past and at times present, as we will talk about with a class of medications called the benzodiazepines, which are used for anxiety. But what we can clearly see now from imaging the brain is that the brain in many areas does not function normally. It is either overfunctioning or it is underfunctioning. There are many different names that are put to these areas of the brain. One of them is the frontal lobes, and I think most of us know what those are. And that's the part of the brain that's here in the front, and that has to do with judgment and foresight and thinking and attention. We know that this is underfunctioning in disorders such as attention deficit. The temporal lobes, which are over the ears, basically, we now know many times are not functioning properly when it comes to issues like anger or mood instability or what we call dark thoughts. Deep inside the brain, there are groups of nuclei that aren't functioning well. There are some that don't function, they actually overfunction when it comes to anxiety, and function improperly when it comes to depression, what we call depression. The basis of almost all medication is rooted in making the brain function normally. Usually, this has to do with what we call neurotransmitters. None of the nerve cells in the brain closely actually touch each other. As you'll see on the screen, we're looking at a little tiny part of the brain called a synapse. A synapse is a connection. There's a tiny little space in there. There are neurochemicals called neurotransmitters that cross that space and are the way that the one nerve cell talks to another nerve cell. In almost every major difficulty in the mental health field, one of these neurotransmitters or a neurotransmitter malfunction is involved. Now, it could be the transmitter itself is not around long enough to do its job properly, or the receptor for the transmitter is not functioning properly. It's very important that you understand this diagram, because all of the medications that I'm going to talk about today can be related back to this basic neurologic malfunction in the hard wiring, or as some people call it, because it's in the neurotransmitters, the wet wiring of the brain. There are three major neurotransmitters that you will hear a lot about. I'm sure you've seen it on television, and people throw these terms around as though they were common knowledge. What I find is that many people are familiar with the words, but they don't know exactly what they mean. There are three common neurotransmitters. One is serotonin, which we've all heard a lot about. The next is norepinephrine. And the third is dopamine. These are the chemicals that are referred to when you hear medications advertised. So you may hear a lot of different kinds of names for different medications. For instance, there are serotonin reuptake inhibitors. Now, that's a fancy term that basically means that serotonin is not staying around long enough to do its job properly. Now, after the serotonin neurotransmitter works, the body repackages it so it can be used again. And then when it gets old, it actually breaks it down and throws it away. A serotonin reuptake inhibitor keeps the serotonin from being repackaged, basically, so it stays around longer to do its job better. Now, something else to understand is that it is really the receptor for the serotonin that's not functioning right. So what we do is we dump a lot of serotonin on this receptor, and when we do that, somehow it makes the receptors turn back on again. Now, whether a receptor is going to work is really, by and large, a genetic problem. People are born with a susceptibility for malfunction in this system. Another neurotransmitter is norepinephrine. So you may hear something like a mixed reuptake inhibitor. That's used very commonly. What that means is that this medication helps serotonin and norepinephrine. The third category, and most of you have seen this on television in one form or another, is the dopamine helpers. These are the ones that are involved primarily with attention, where there's not enough dopamine around to do its job properly. Now, in a particular disorder called schizophrenia, the receptors for dopamine are actually hyperactive. They spark off like old wiring in an old building, where if you plug the plug in the socket, everything goes shoo, because the wiring isn't good. In schizophrenia, the receptors don't function properly, and so you actually, if you have a normal amount of dopamine, it causes the receptors to misfire, and then the brain has all sorts of odd information that it perceives, such as hearing your thoughts out loud, which is really what it is. Now, people may say they hear voices, but actually what they're doing is they're hearing their own thoughts out loud. The way we help that is we block dopamine. We put something in to block the receptor so that even a normal amount of dopamine is reduced in its effectiveness, and that helps the symptoms get better. So, we have we have a receptor which can either downregulate or turn off, or we have a receptor that can be faulty. Then we have at least three, and probably many more, neurotransmitters. These are the three we know a lot about: dopamine, serotonin, and norepinephrine. And there may not be enough of these around to do their jobs. So we do something to help these three neurotransmitters stay around in one place long enough for things to work properly. If you look at the slide, there are several general classes of psychiatric medications. These are the medications classes that you're going to hear when someone's talking about different kinds of treatments. First, there are the antidepressants. Now, many people misunderstand what antidepressants are. They aren't uppers. If you take an antidepressant and you don't need it, it's like an antibiotic. It's not going to do anything for you. If you have plenty of serotonin and your brain is functioning normally from that standpoint, and you take a serotonin helper, the only thing you will get are side effects. The next category are mood stabilizers or anticonvulsants. Now, the most familiar one in that category is lithium, but we'll cover this specifically later. But these are mood stabilizers. These are for people whose mood is not stable. So it could be that they're doing okay and then they get really angry, or it could be that they have rapid changes in mood. That 1 minute they're feeling really good and then it crashes. But the hallmark for this particular class is mood instability, that it changes frequently. The third class we're going to look at are the anxiolytics. These are medications that reduce anxiety. Actually, these are the ones that people probably have more trouble with than anything else except for the narcotics or the painkillers. These are the most familiar one in this class that we all knew about in the 70s and 80s was Valium. Now, this is truly a category of medication where if you take it for the wrong reasons, then you really are avoiding dealing with things. You can numb yourself out. So this is a class that you have to be careful with. That does not mean that it can't be used properly and used well in the right circumstances. The next category are the antipsychotics. Now, everybody gets scared of the word antipsychotic, or its more familiar name is called a neuroleptic. But as soon as you look it up on the web, and everybody looks everything up these days, you're going to see antipsychotic, and then you'll get really upset if someone wants to give your child an antipsychotic. They're actually, what these are, as I referred to earlier, these are dopamine blockers. So, if the receptors aren't functioning properly, and the example I gave you before was schizophrenia, but there are many other circumstances under which the dopamine is overreactive, and we may use these dopamine blockers to calm things down. The last class that we'll talk about are the psychostimulants. The familiar ones are Ritalin and Adderall. These are medications that are used primarily for ADD, but can also be used for things like narcolepsy, which is it's an odd condition where you can be standing up and suddenly you fall asleep. Now, in the most extreme cases, people fall asleep on their feet and fall to the floor. But there are a lot of milder cases, and we call it, we have these names in medicine. So it's the idiopathic, meaning we have no idea what causes it. Hyper, too much of, somnolence, sleepy. So what we have is someone who's too sleepy all the time and we can't really explain it. But stimulants will help with this, and there are people who really have trouble with this, sometimes in children and adolescents, although that's not as frequent. Another thing that is very important to understand is how are medications named. Now, there are two categories. The first is generic. Now, what the generic name means is this is the chemical formula for the basic compound. For example, methylphenidate. Methyl is a chemical name for a kind of carbon group. Phenidate is the basic compound. And so methylphenidate is the chemical compound that gets manufactured and marketed. Now, when people manufacture something and market it, they put their own name on it, primarily so they can charge more. Now, a brand, and that's called a brand name. There's a lot of controversy about brand versus generic. What I can say to you is that brand and generic aren't equivalent. The standard for manufacturing medications is somewhat different, and so what you may get is a generic brand that 1 month doesn't work quite as well as it did the previous month. By and large, if you work with it enough, you will find you'll be able to use generic. But brand is, in my perspective, much more predictable, and certainly in the beginning, personally, if I can get it, I prefer brand. Insurance companies don't like brand. The pharmacies tell you that there isn't any difference, but there is a difference in the inert compounds and in the way medications are prepared, particularly in something called bioavailability, meaning how much of it actually gets into your body when you take a pill. You hear this about vitamins, and vitamins are different too. You know, if you take a liquid one, you get more in. Same thing with medications. Some of them get in the body, some preparations get into the body better than others. Now, how do you figure out which one? That's really very difficult. And by and large, if you have to use generic, we can make those work. The brand name is what everybody hears on TV. For example, Zoloft is sertraline. That's its generic name. But Zoloft is the brand name. Methylphenidate is the generic compound for the stimulant that most people know of as Ritalin. Now, Ritalin has a half twin called Focalin. Again, this is where it gets complicated. The people that make Ritalin took a lot of the compound out that was inactive and threw it away. And then they remarketed what was left as Focalin. It's the same company. Now, it actually does have a better side effect profile. But the insurance companies protest because it costs them more to get this medication. What you also need to know is that you can go in and request exceptions to what are called formularies, which are what the insurance company tells you you can get or not get under your insurance plan. I don't want to get too far into that except to give you some idea that you have choice, that you can actually go back and say, well, I know this isn't approved, but we know this works in my child. And there is a process whereby you can go back to the insurance company and request an exception. And many times we do that with success. Under the antidepressant classes, and I've referred to this before, there are several different kinds. These are the names you're going to hear. The serotonin reuptake inhibitors, the tricyclics. Now, tri means 3, cycle is ring or circle. So if you look at the compound, what you see is that it has 3 ring structures connected. It's really not as complicated as you think. These are old antidepressants, though, with a lot of side effects, but they still have a lot of usefulness. Monoamine oxidase inhibitors. Now, this is a class that you don't hear of, except that when you go to the pharmacy and you get an antidepressant, what they're going to say is, don't take this if you're taking MAOI. And everybody says, well, what's an MAOI? Well, it's a monoamine oxidase inhibitor. Now, well, what's that? Well, remember I said that when these neurotransmitters are used up, that the body breaks them down? Well, this is how it happens. There's a monoamine, meaning one amine, inhibitor, an oxidase. So what it does is it breaks the compound down. You can take a medication that actually prevents that from happening so that the body doesn't break it down as rapidly, and that helps it stay around longer. They're actually good medications, but they have certain dietary restrictions, and so people don't use them very often. I've already mentioned the dual reuptake inhibitors. And then there's a lot of what we call others. Medications that don't fit into a particular class or subclass, but they have specific usefulness for specific reasons. You'll see on your screen a list of antidepressants, a very tedious list. What I've done is given you the generic name first, and then the brand name or names after that. So if you want a reference, and this will be in your handout or your manual as well, and you want to say, well, what is that? You can go back and look at either the brand name or the generic name to tell what kind of medication it is that you're considering. There are several listed. The most familiar antidepressants for most of you will be Zoloft, Paxil, Celexa, and Lexapro, and Prozac. Those are the ones that seem to be used most commonly, and there's a good reason for that. It's very hard to kill yourself with those medications. The older medications, like the tricyclics, are medications that are really pretty dangerous in an overdose, and it doesn't take much to get toxic on them. So if you have someone, and in depression many times people are in such pain that they don't want to live any longer, if you have someone like this and you're giving them a tricyclic, you're going to have to be careful to give them only a certain amount and to monitor it more closely. Now, that doesn't mean you shouldn't monitor someone just because they're on a medication that it's not going to kill them if they overdose. But if they should overdose on the serotonin helpers, they're really not going to die. They may get very sick, they may have a seizure, but they're not going to die. The other category of antidepressants, Remeron is one that it has an odd name. The generic name is mirtazapine, but it's been around. It's very good as an antidepressant. Cerazone, though, is something that's been out, and now no one has it much anymore because there were some liver problems. What I should point out, though, is that just because there were some problems with some medications does not mean that the medications aren't good and that they shouldn't be used if necessary. What it means is that we need to be careful diagnostically, and we need to monitor, and we need to follow people. And too many times people are given medication, they're not given a good, thorough clinical examination, and then they're not followed very closely. The next class are the mood stabilizers. I said before, lithium is the most common medication in that category. Lithium was discovered by accident. In the olden days, when a lot of people had tuberculosis, and some of you may be familiar with the tuberculosis sanitariums. Actually, my grandmother, when my father was young, was sent away to a sanitarium where they used an old technique where they would collapse the person's lung and suffocate the tuberculosis organism. Now, in these groups of people, they tried lithium to see if this would help tuberculosis. And they noticed that there were some people whose moods got very good while on the lithium. So then they began to study it more closely and found that indeed there was a psychiatric disorder called then manic depression. Now we call it bipolar, two poles, the up pole and the down pole. So classically, these are people whose moods are very elevated or very depressed. And what we found was with lithium that these moods were stabilized. The highs weren't as high, the lows weren't as low, and it was more of a normal range of experience. After that, we discovered that anticonvulsants also served the same purpose. Some of the older ones are Depakote, and that's Tegretol. These are ones that are very familiar to people generally. They have their own side effects, mainly weight gain and trouble thinking, and sometimes hair loss, which made it very unpopular. On the other hand, if you were going to have a life that was out of control, sometimes these medications were very necessary. If you think of it as having an emotional seizure, which is actually probably close to what's happening in the brain, because in the disorders that these anticonvulsants treat, there is a great deal of mood instability. And so the mood is stabilized and evened out. Probably the most familiar one, some of the more familiar ones are Lamictal. I happen to like that a lot. It's a newer one. It has an antidepressant indication as well, so you can get mood stability and an antidepressant treatment at the same time. The next category are the anxiolytics, also known as the hypnotics. There are lots of names for these. There may be as many as, I think, 35 different ones. Probably the ones that are most familiar to you will be Xanax, which is sort of the Valium of the 90s, and Ativan. Now, Ativan is used a lot with elderly, and that's mainly because it's not processed in the liver. So if you have any liver problems, you're not going to build up a level of it. But it is also a very good short-acting anti-anxiety medication, and used properly is many times indicated. Xanax is very useful in genuine panic attacks. So when a person has a panic attack, and by that I don't mean just being anxious. I mean, if you're short of breath, sometimes people think they're having a heart attack, they feel like they're about to explode, that their heart's beating out of their chest, although oddly when you look at them, it won't necessarily show on their facial expression. So when someone says, I think I'm just gonna die, then they may get the response, well, really, you look fine to me, which then really makes you feel crazy. But Xanax will really abort a panic attack. It's a very good medication for that, but you can build up tolerance to it, so it needs to be used properly. There are the sedative hypnotics, and a lot of those are the same medications as Valium and Xanax. That's the class that I call benzodiazepines. What they do is they reduce anxiety, and that helps people sleep. But they don't actually promote a normal sleep pattern. So many times people who take these medications, if they're having anxiety as a primary problem, and that's why they can't fall asleep, they may do better. If they have a sleep disorder and they take these, while they may sleep, they may feel hungover the next morning. There is another category called, and everyone is familiar with the main one in this category, which is Ambien. There are actually three: Ambien, Sonata, and Lunesta. These are ones that you've seen on television. What these do is they promote a normal sleep pattern. So if you look at someone's sleep when they have and it's called a sleep EEG, and it's abnormal, and you give them one of these three medications, and you redo it, their sleep pattern looks normal, or more closely normalized. And that's why they wake up feeling refreshed, feeling like they've had a good night's sleep. The next class are the antipsychotics. I'm not going to go much into these except to mention some that are well known. The first is Risperdal, and Clozaril. Clozaril is used with schizophrenia, was probably the first highly successful new medication to come out for schizophrenia in many years. But in this category, many times, children with mood disorders or meltdown or anger or even sleep disorders will be given medications in this category, such as Seroquel, which in a low dose can be very sedating. You might also find some in this category for children with Tourette's disorder. Orap and Haldol, both for reasons that are not clear, can help in Tourette's, although the other neuroleptics don't help very well. We don't know why that is. The last class, and probably the most controversial in some areas, are the psychostimulants. These are the ones that we use to help dopamine, and these are the ones that we use for attention regulation or deficit disorder. The most common one is probably, or the common two are methylphenidate, which, as I said before, most people know as Ritalin, and dextroamphetamine, which most people know as Adderall. These medications come in different preparations, so you can get long-acting, intermediate-acting, and short-acting. The most common combination is to have a long-acting, which is about 8 hours, to get through the school day, with a short-acting in the afternoon to get through homework. But the protocol has to be varied. Now, there is something else called Strattera, which is not a stimulant that is used for attention, and it hasn't been as successful. Listening to people describe it, the stimulants help put people on task so they feel more focused, they feel more present in what they're doing. Strattera seems to help people notice that they're drifting. So instead of being down the road and go, gee, I'm completely lost, they feel themselves drift, and then they have to work to bring it back. So it has a different mode of action, but in people who can't tolerate the stimulants, and sometimes that's the case, they may be very helpful. There are different categories that are used for different reasons, and I put these under other. If you will look, we'll see this on the screen. First is the antihypertensives, oftentimes used for hyperactivity and for tics. The antihistamines, which Benadryl is probably the most prominent one, and most parents know a dose of Benadryl occasionally at bedtime is very useful. There is a class called anticholinergics. Now, this is to help the side effects from dopamine. Once you block dopamine, the side effects sometimes are very troublesome. So unfortunately, we have to give something else to block the side effects. What can you tell from a diagnosis? This is one of the big problems that I see, is that people throw at diagnoses as though they mean something. I think it's very important when someone comes in and says, well, my kid has depression, or my kid has bipolar disorder, you have to say, what do you mean by that? What are the symptoms? Because different people have different symptoms. And the diagnosis in and of itself doesn't prove or disprove anything. A diagnosis is a convenient way of grouping symptoms so that clinicians and parents can talk to each other about what's going on. But you have to describe individually what's going on with each child or adolescent. In the next slide, I've listed all the different kinds of diagnoses that are potentially out there. As you can see, there are a lot of them. There's not time to go into them, not into each one of them, but I wanted to familiarize you somewhat with just the spectrum of problems that people can have. It's very important to understand a concept called off-label use of medications. Basically what this means is that the FDA approves medications for certain uses. So when the pharmacy company applies, they say, well, and they only have one use. So they'll say, well, we want to use this as an antidepressant, so it'll get approved. Now, that's only for the pharmaceutical company's restriction. They can't market their medication for anything other than what the FDA has approved it for. The doctor can use the medication any way that the doctor wants to, as long as he or she can support it medically. So that means that there are a lot of quote-unquote off-label uses of medication. So, for example, Seroquel, which is an antipsychotic, may be used in low doses to help sleep. If the doctor can justify this medically, that does not mean that it's malpractice. It does not mean that they're doing anything wrong or illegal. It is a very common practice to figure out, and we do this over time, what works for what. And then the companies may go back in and request additional indications. A lot of times they don't. But when you look up a medication, you may say, well, gee, this is approved for thus and such, so what's my doctor giving it to my kid for? Well, there are good medical reasons for it, and those are reasons that you should ask about and try to understand. But just because a medication is used off-label does not mean that there's anything wrong with it. It still may be the best medication for that particular symptom. Another common problem is polypharmacy. Many times you're going to find that the recommendations are for more than one medication. One size does not fit all. What we can see from imaging the brain is that different parts of the brain are either over or under functioning. So depending on which part of the brain is over or under functioning, we may have to choose a different medication for each part of the brain. Sometimes that feels to parents like we're just throwing medication at children, but actually we're not. We're trying to take each symptom cluster and treat that with what is appropriate for that symptom. And it may be that in order to get control of everything, we have to use more than one medication. The last thing we need to look at are what symptoms are medications used for. And I have provided a list for you of the different kinds of symptoms and the medications and the classes of medications that are used for each symptom. We can't go into each one here, but it is in your handout for you to look at, so that when your child, your adolescent, or your spouse has a certain symptom and a certain medication is recommended, you can see the different kinds of medications that are used for that particular symptom. For example, in obsessive compulsive disorder, where it can be being stuck on thoughts in your mind or stuck on behaviors such as hand washing. Sometimes people have very dark thoughts that they're afraid they're going to do something evil. But there are many different medications that can be useful. For example, the serotonin reuptake inhibitors, but also one called anafranil, which is a tricyclic, if you remember the description of that. And also the neuroleptics. So sometimes people will take Giadon for obsessive thinking. The important point is that we take a symptom and we treat the symptom with the medication that works best for that symptom. And sometimes, for reasons that aren't clear, medication that works for one symptom in one person will not work for that symptom in another one, and we have to use another medication. Sometimes one medication is used to start with, and for example, in manic depression, and then another medication is changed to another medication later on, because one medication may help in the initial phase, but in the maintenance phase, another medication may be best. Side effects are very irritating. Side effects can be physical. Sometimes they can be very subjective. Sometimes what I hear from people is they don't feel right. They feel foggy or they feel medicated and they can't put a word to it that makes sense. But I think you have to take that seriously. I think parents, particularly mothers, can observe their children very clearly, and so they may see side effects that the child themselves are not aware of. There is a list of the different side effects for the different classes of medication. When it comes to children and adolescents, fortunately, the main side effect for the serotonin group is not something that we have to consider. And those are the sexual side effects. Those tend to affect adults much more. They're actually fairly benign in terms of side effects for children. Stimulants, as we all know, will postpone appetite. It's not that it takes it away, it postpones it. So the pattern is they don't eat during the day and then they put the refrigerator in their mouth when they get home at night. The side effect for the anxiolytics, the main one, is building up tolerance, meaning the more you take, the more you have to take to get the same effect, and over a long period of time, and it takes a lot of work to do this, you can get physically addicted to this class of drugs. Now, monitored properly and used properly, that doesn't happen. So if someone is not taking it the way it's prescribed, or they're trying to take it every day, then I'm going to restrict that with the person. Again, I think part of it is how closely they're monitored and how carefully the medication is used. The last thing I'd like to cover are the warnings that have come out recently. They're very interesting in that everyone seems to know about the warning from the FDA about increased suicidal ideation. Now, there seems to be a very slight increase in thoughts of suicide with Paxil. But when it comes to all of the rest of the medications, there isn't anything that supports an actual increase in ideation. It's still an area of concern, and most of these medications have what we call black box warnings, which means you should be careful. Part of the question is are the suicidal thoughts part of the illness, and are they part of the medication? Well, the FDA, when they first put out their warning in the New York Times, said that suicide as a side effect of medication is such a rare event as to be impossible to evaluate. So the first thing I would say is to remember they're saying thoughts. They're not saying actual suicidality. The other is that you look at when the warning, the time of the warning. The time is when you're starting an antidepressant or when you're changing from one to the other. Well, one function of depression itself is that in the beginning, when you're starting on an antidepressant, if you're very depressed, you can actually gain some energy and still be suicidal enough to act out on it. It's still the illness. Or when you're changing from one to another and the medications are dropping in your system. That's a well-known risk factor that has been around for years. Unfortunately, the concern about medication and suicidality and the casual use of medication has really led many people to avoid medication altogether. What we can say with absolute certainty is that the number of completed suicides is far greater off of medication than on medication. So the real question is a risk-benefit one. What are the risks of not treating? And do the benefits of treating outweigh the side effects and the risks? Once those questions are answered clearly, the use of medication is not as controversial as many people think. The good news is that we are so much more sophisticated now than we've been in previous years. We know what areas of the brain respond to different medications. And clearly we are able to help people in a way that we've never been able to help before. And the only direction that we have to go in is forward. So when you are considering medication or when someone brings medication up, please think about it, listen to it, be encouraged by it, ask the right questions, and do for your child or for yourself what we know can be done.